Hey everybody. So just real quick, this is interesting. So there's been a controversy, and I've gone back, I've heard different stories from different people, and it's like this has been a weird discrepancy because there's been people who've been very advocate about what it's doing to everything, and I feel like that's always made good sense to me. So I've been along those lines. But then there's been people that have come out and said that those people that initially talked about it were lying and they were just doing it to create fear. Da, 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 da. But when you look into the science is based on the information that is available to me where I'm at is telling me the general consensus from AI is telling me that there's a huge indicator. There's many indicators that show that carbon monoxide from car emissions is incredibly horrible for humans and the animals and the planet. Um, but Joe Rogan has argued this. Others have argued it, and I know that people that are also involved in really funky stuff have been proponents of this. So it's hard to trust these things. So this is why we need to get the experts and break down the truths and do experiments so that once and for all we can prove and have hands down documented proof of what this is actually doing. All right, so anyways, just to further again to check my sources and stuff, I was gonna go ahead and just click this link to see what this website has because they're the ones that are telling you that carbon monoxide is 220 times more strongly than it binds to our bloodstream, 220 times stronger than oxygen, therefore pushing oxygen out. Means that the more of that we inhale, the less oxygen we get, which is what we need to survive and be healthy and happy. This is also another way to dumb us down, because the less oxygen you have in your brain, the less intelligent you are, the less healthy you are, and the less well-being. Like, you don't feel as good. You're more anxious, you're more fearful, you're more stressed out, you have less energy, it's harder to breathe. All of these things are bad. All of these things go against what the government of America is supposed to do, which is help govern the people in a good way for their well-being. This is exactly against our well-being. So this is why sources like this, if they're legit, this type of stuff needs to be everywhere, shown everywhere, because we need to start making changes now. Not tomorrow, not the next day, not in a year, now. So as I go to look into this source, this is what happens. Maybe it'll go through. Oh shit, look at that. So I shit you not, earlier when I did this, it went to a government blocked page. I wonder if it's still up. No. Yeah, see, initially this is what popped up was so anyways, I've only seen this. This may be the first time I've ever had this server error pop up. I usually don't click links when I'm going through AI and shit, so I don't know if that's a factor, but I'm glad that it did show up. So, alright, this is the information. Carbon monoxide is a tasteless, odorless, and colorless gas that can cause severe illness or death when inhaled at high concentration. Unintentional exposure to carbon monoxide accounts for more than 100,000 emergency department visits, 14,000 hospitalizations, and 400 deaths annually in the U.S. worldwide. In the U.S. Okay, worldwide carbon monoxide poisoning is responsible for over 28,000 deaths annually. I guess they're saying that this is just from carbon monoxide. Which I guess it would be instances like the one with the NBC case, right? We talked about the whole family of 7 unfortunately dying. That's what I'm assuming would be attributed to just carbon monoxide. But what they're not factoring in, though, is how many lives are, this is where it's a number of things. Like when people have heart attacks, it's their heart that eventually is giving out, but it's a number of lifestyle aspects of their life that have pushed them, have cultivated them to get to the point where their heart collapses or their heart stops. So this is another aspect in our American society that is making life more difficult than it needs to be. because we have other ways of producing energy, we have other ways of producing fuel and moving and locomotive ways of transportation that do not have to rely on such poisonous materials. But yet, for reasons that I think are just purely evil, aka greed, we're choosing to use these toxic, horribly pollutant chemicals and fuels when we don't have to, for greed, which goes completely against the U.S. Constitution, which is why it is illegal and it should be illegal. And until we start making these things illegal, it's not going to start getting better. Individuals exposed to carbon monoxide are often slightly symptomatic or unconscious before poisoning is recognized. The signs and symptoms are nonspecific and may delay diagnosis. Patients commonly report headache, weakness, dizziness, nausea, vomiting, chest pain, or neurological symptoms. Clinic manifestations range from mild flu-like symptoms to stroke-like deficits, cardiovascular collapse, and death. Diagnosis is confirmed by elevated carbohemoglobin, it's exactly what they were talking about, levels on co-oximetry guided by clinical suspicion based on symptoms of exposure history. Management involves prompt removal from the exposure source, administration of 100% oxygen, and consideration of hyperbaric oxygen therapy in severe or neurologically symptomatic cases. Early detection and treatment are critical to prevent morbidity and mortality. An interprofessional approach is essential to promptly diagnosing and treating individuals with severe poisoning. This activity for healthcare professionals is designed to enhance learners' proficiency in evaluating and managing carbon monoxide toxicity. Participants will gain deeper insights into the carbon's etymology, pathophysiology, and clinical presentation. Evidence-based diagnostic and therapeutic approaches will be emphasized. Greater competence will prepare clinicians to collaborate within an interprofessional team caring for patients with this condition. Identify the signs and symptoms suggestive of carbon monoxide toxicity. Assess the severity of carbon monoxide poisoning using co-oximetry analysis and other diagnosis tests, including arterial blood gases and chest x-rays to guide treatment decisions and determine the need for interventions like hyperbaric oxygen therapy. Apply individualized management strategies for carbon monoxide toxicity. Implement effective collaboration and communication among interprofessional team members to improve outcomes and treat efficiency for patients experiencing carbon monoxide poisoning. Carbon monoxide is released from the environment during the incomplete combustion of carbon compounds. This gas is tasteless, odorless, colorless, and non-irritating to mucous membranes or skin. These characteristics make it essentially undetectable by human senses, allowing toxicity to develop gradually. The effects of carbon monoxide poisoning vary and may mimic the symptoms of more common diseases. Clinical presentation can range from asymptomatic to cardiovascular collapse and death. A high index of suspicion is essential for prompt identification and treatment. Etiology. Carbon monoxide toxicity occurs due to hyperoxic ischemic cellular injury caused by carboxyhemoglobin formation. Exposure to high ambient levels of carbon monoxide is necessary for toxicity to develop. Common sources including cooking appliances, vehicles, generators, heaters, and structure fires. Exposure is poorly ventilated in closed spaces increases the risk of toxicity. Additionally, colder weather correlates with higher rates of carbon monoxide poisoning, likely due to the use of faulty or alternative heating sources in confined spaces. Etymology. Annually, over 40,000 cases of carbon monoxide toxicity in the U.S. result in emergency department visits. Of these instances, 14,000 lead to hospitalization. Among hospitalization individuals, approximately 2% ultimately die. Around 10% of admitted patients experience partial recovery, and 23% to 47% suffer delayed neurological sequelae. Over 400 to 500 deaths annually are attributed to carbon monoxide toxicity. Overall, as many as 30 to 40% of carbon monoxide poisoning victims die before reaching the hospital. significant toxicity and death from unintentional exposure have recently overtaken that of intentional exposure to the U.S. Globally, male patients have a higher hospitalization rate, and the male mortality rate exceeds that of female patients. Children aged 0 to 9 years experience the highest rate of poison center calls and emergency department visits, while patients older than 80 years are most likely to require hospitalization. The majority of carbon monoxide exposures are reported in residential settings. In the U.S. workplace, exposures are the next most common, followed by schools, healthcare facilities, and other public areas. Carbon monoxide is also a leading cause of death among the victims. Pathophysiology. Carbon monoxide binds to hemoglobin to form COHB, which is the 200 to 250 times greater affinity for hemoglobin than oxygen. COHB formation reduces the oxygen carrying capacity of hemoglobin and leads to cellular hypoxia. This moiety also increases the affinity of unbound hemoglobin for oxygen, causing a leftward shift in the oxyhemoglobin dissociation curve and reducing oxygen delivery to tissues. The shift results in lower intercellular partial pressure of oxygen, PO2, than expected for a given blood oxygen concentration. While the hemoglobin concentration and measured PO2 in the blood may appear normal on laboratory tests, the oxygen content of the blood is significantly reduced. Carbon monoxide also binds to the moiety of cytochrome C oxide in the electron transport chain, inhibiting mitochondrial respiration. The resulting buildup of reactive oxygen species contributes to cellular damage or death. The normal carbohemoglobin in non-smokers is less than 3%. The carbohemoglobin in people who smoke may be as high as 10%. A carbohemoglobin as 10% suggests additional carbon monoxide exposure even in people who smoke. Carbon monoxide enters the body through the lungs and may damage the lung parenchyma. Sorry if I mispronounce things, though local biochemical interactions. The gas crosses alveoli to bind with hemoglobin in the bloodstream, forming COHB and disseminating throughout the body. Carbon monoxide causes capillary leakage of micromolecules from the lungs and systematic vasculature, which can occur even with prolonged exposure to relatively low ambient concentrations. As COHB levels rise, cerebral blood vessels dilate and coronary blood flow and capillary density increase. Continued exposure may result in central respiratory depression due to central hypoxia. Cardiac ventricle arrhythmias may develop and often contribute to death in cases of carbon monoxide toxicity. Myocardial impairment has been observed at COHB concentration as low as 20%. Toxicokinetics. Hemoglobin combines with carbon monoxide 220 times more avidity than it does with oxygen. On room air under 1 atm of pressure, 1 atm oxygen concentration 21%, the half-life of carbon monoxide is 320 minutes. At 1 IM pressure with 100% oxygen, the half-life is reduced to less than 90 minutes. With hyperbaric oxygen as pressure of 3 IM, the half-life decreases to approximately 23 minutes. Hyperbaric oxygen therapy, HBOT, reduces the potential toxicity of carbon monoxide by accelerating its elimination from the body. These are the cities that we live in, that we pay taxes for, that to a government that is supposed to perpetuate our well-being, and yet they allow this. History and physical. The presentation of carbon monoxide toxicity varies depending on the level of exposure. The most common symptoms reported in sympathetic unintentional carbon monoxide toxicity include headache, nausea, dizziness, or vertigo, drowsiness or fatigue, and vomiting. Less than 3% of patients report cough, confusion, shortness of breath, syncope, chest pain, weakness, or throat irritation. Vital signs and physical examinations may be unremarkable in patients with mild or moderate poisoning. However, individuals with severe toxicity may present with tachycardia, tachypnea, or hypotension. Only 1% to 2% of patients evaluated for carbon monoxide exposure are tachycardic. Mental status changes such as confusion, altered level of consciousness, disorientation, and memory loss may occur. In intraocular finding can include retinal hemorrhages and congestion with papillodermia. Additional neurological findings may include ataxia, apraxia, incognito, and correctional blindness. They classically describe signs of cherry red nail beds and mucous membranes are typically postmortem findings and should not be relied upon for diagnosis. Evaluation research resuscitation of severely poisoned patients begins with stabilization of the airway. Speaking of which, breathing and circulation as with any critically ill patient. That's interesting how they include this, yet it's one of the few times I've ever heard somebody speaking about how it should be for any critical ill patient. It is all about your circulation and your breathing, but you don't really hear about that very much. Supplemental oxygen remains the cornerstone of treatment. However, standard peripheral pulse oximeter devices cannot distinguish COHB from oxyhemoglobin. High-flow oxygen therapy, it can rapidly reduce the levels of carbohemoglobin COHB by displacing carbon monoxide from hemoglobins, leading to an inaccurate interpretation of COHB levels when using CO2 oximetry. Consequently, bedside assessments of oxygen saturation cannot be relied upon. An arterial blood gas sample with co-oximetry analysis is necessary to determine COHB saturation. Arterial and venous blood have comparable levels of carbohemoglobin. Therefore, in hemoglobin-stable patients, venous blood gas can be used as a surrogate for arterial blood gas sampling. In carbon monoxide poisoning, arterial blood gas analysis may show a normal partial pressure of oxygen. Co-oximetry is necessary to measure carbohexammoglobin in blood, a marker of carbon monoxide exposure. Since COHB levels correlate poorly with its clinical symptoms, they should not be used in isolation to guide treatment decisions. COHB levels greater than 3% to 4% in non-smokers and greater than 10% in smokers are considered abnormal in otherwise healthy individuals. Levels exceeding 20% in adults and 15% in children suggest significant poisoning. Additional laboratory tests may include a complete blood count, electrolytes, blood, urea, nitrogen, creatine, and baseline troponin. An electrodiagram should be obtained to evaluate for signs of ischemia. New ischemia changes are indicative of severe carbon monoxide poisoning. Chest radiographs are also recommended. If cerebral imaging is performed, findings may include a globius pallidus hemorrhage. Treatment-management. The first step in treatment is immediate removal from the carbon monoxide source, getting out of the cities. Supplemental oxygen should be infiltrated without a delay. Oxygen delivery may involve normobaric oxygen therapy, using a nasal cannula or face mask or HBOT in service cases. Supplemental oxygen enhances carbon monoxide clearance by increasing the PO2 in the lungs. The half-life of COHB is approximately 4 to 6 hours on room air. With normobaric oxygen therapy, this interval is reduced to 40 to 80 minutes. With HBOT, the COHB half-life decreases to 15 to 30 minutes. Indications for HBOT vary. Commonly accepted criteria include neurological deficits, transient loss of consciousnesses, cardiac ischemia, altered mental status, persistent metabolic acidosis, pH less than 7.1 to 7.25, end organ ischemia or hypertension. Patients with COHB concentrations greater than 25% in adults and greater than 50% to 20% in pregnant individuals are also considered candidates. Although hyperbaric oxygen facilities are available in every state, only several hundred centers operate across the U.S. The best outcomes are observed when treatment is initiated within 6 hours of exposure. Most hyperbaric physicians administer 3 sessions within the first 24 hours, followed by reassessment of the patient's symptoms and response before continuing with daily sessions. Notably, some individuals with significant neurological injury have experienced remarkable recovery following HBOT. However, up to 40% of patients develop chronic neurocognitive impairment despite treatment, and these individuals should undergo neuropsychological evaluation approximately 1 to 2 months after recovery. Case reports describe the successful resuscitation of critically ill patients with carbon monoxide toxicity using extracorporeal membrane oxygenation. which facilitates carbon monoxide removal, improves circulatory and respiratory support. Specific criteria for ECMO initiation in this context remain undefined. Few alternative treatments currently exist. Ongoing research explores the use of reactive oxygen species, scavengers, and agents that directly bind carbon monoxide. Pulmonary phonotherapy, both alone and combined with ECMO, is under investigation. Although therapies such as methylene blue corticosteroids and hydrocobalamin with ascorbic acid have shown promise in animal studies, human trials remain limited. Differential diagnosis. Given its non-specific symptoms, carbon monoxide toxicity can resemble a wide range of medical conditions, making the differential diagnosis broad and challenging. However, clinicians should consider the following potential mimics in more severe presentations: alcohol toxicity, opiate toxicity, other sedative hypnotic toxicity, methylmoglobinuria, depression, diabetic ketoacidosis, hypothyroidism, hypoglycemia, labyrinthitis, meningitis, encephalitis, migraine headache. Careful clinical assessment, history taking, and targeted investigations are essential to avoid misdiagnosis. Prompt identification of carbon monoxide exposure can prevent unnecessary delays in initiating life-saving treatment. Prognosis. Fortunately, patient mortality and mortality from carbon monoxide toxicity have declined over time. That's good. Likely due to increased community awareness and public health efforts. The prognosis for patients with significant carbon monoxide exposure varies based on the intensity of exposure, initial clinical presentation, and comorbidity. Severe exposures may result in long-term neurological and psychiatric sequelae. So they say this, that the actual death from just the cause of carbon monoxide poison is reduced, and I'm glad that it has. What I think that they should have included, maybe they will, is the increased effect it's having on the cumulative illness of the population. Because what has risen is the overall sickness of Americans. And I think this is I know this is part of it. Certain baseline laboratory tests and imaging studies can help predict recovery in the most severe affected patients. For example, individuals with abnormal findings on brain magnetic resonance imaging or head computed tomography attributed to carbon monoxide exposure generally have poor long-term prognosis. Patients with low Glasgow coma scores on presentation develop persistent neuropsychiatric sequelae at high rates, particularly when the initial score is below 9. Persistent focal neurological deficits also indicate a poor overall prognosis. HBOT reduces the incidence of cognitive sequelae in some patients. Complications. Acute complications of carbon monoxide toxicity stem from end organ dysfunction due to ischemic injury and may improve with supplemental oxygen and supportive care. In contrast, long-term sequelae are predominantly neurological and psychiatric, often irreversible. These conditions include the following: amnesia, dementia, irritability, psychosis, memory loss, loss of executive function, speech deficits, Parkinson's disease, depression, choroidal blindness. I have a feeling there's a rise on all of these. Save that for later. Persistent symptoms can significantly impair a patient's quality of life and daily functioning. Early recognition and appropriate treatment are critical to reducing the risk of long-term sequelae. Deterrence and patient education. Carbon monoxide exposure is often preventable, especially in residential settings. Patients should be educated on the importance of installing functional carbon monoxide detectors and using cooking and heating equipment properly. Household appliances should be routinely inspected to ensure they are not releasing carbon monoxide. Generators and alternative heating sources must never be used in enclosed spaces. And alternative heat enclosed space, everybody uses their heaters in houses. I mean, it's just stupid. Anyway, pearls and other issues. The diagnosis of carbon monoxide toxicity cannot be made without considering in it the differential. Suspicion should be raised when multiple individuals from the same household or location present with similar symptoms. Poisonings are more frequent during the winter months, often due to improperly vented or poorly maintained heating units. House fires and suicide attempts are common causes of carbon monoxide toxicity. And scuba divers are also at risk if tanks are filled near a poorly ventilated generator. Cyanide and carbon monoxide poisoning often occurs synergistically in cases of exposure to fires. Hydrocobalamin is an antidote to cyanide poisoning. And it interferes with measuring carbohemoglobin in carboxyhemoglobin in the blood, detecting a falsely low carboxyhemoglobin level. Therefore, hydroxycarbonobulin, leads to a falsely low level of carboxyl, enhancing healthcare team outcomes. Unintentional carbon monoxide poisoning is a leading cause of preventable deaths in the U.S. Wow, right there. Unintentional carbon monoxide poisoning is a leading cause of preventable deaths in the U.S. With symptomatic patients often presenting to the emergency department, a high index of suspicion is crucial for making an accurate diagnosis. Early identification and intervention rely on awareness of carbon monoxide toxicity and its varied presentation. A team approach is necessary to optimize patient outcomes. Care for patients with severe toxicity requires collaboration with specialists in toxicology, hyperbolic medicine, and critical care, depending on the severity of toxicity. Providers must be familiar with the indications for HPOT and quickly transfer patients to hyperbolic centers when appropriate. Patients should be monitored closely for mental status changes, arrhythmias, cardiac ischemia, and hypertension, with escalation of supportive care and oxygen therapy when needed. If the exposure was the result of a suicide attempt, a mental health consultation is required before discharge. Healthcare teams play an essential role in educating patients and families about installing carbon monoxide detectors. Despite prompt treatment, approximately 40% of patients experience residual neurocognitive impairment. These individuals may require ongoing care, including physical therapy, occupational therapy, or home services. Alright, well, thank you very much to the people of National Library of Medicine, National Center for Biotechnology Information, by a Kathleen McMahon. Sorry if I mispronounced that. And Marjorie V. Laninko. Sorry if I mispronounced that. Thank you guys for your good work. I appreciate it. All right, good day.